Hello and welcome to the Triage Method podcast with me, Gary McGowan, Patrick Farrell, and Dr. Nicola Flanagan. Very happy to have you guys here again. We're continuing with the female series, and today we're going to be talking about polycystic ovarian syndrome, or PCOS, which you may have heard of. It's actually an area that has a surprising amount of kind of quackery attached to it, and that's probably because there's not necessarily that much like high quality evidence on conventional medical approaches, I guess you could say. And anytime we see that happen, what ends up kind of filling that gap is a lot of the functional medicine and supplement side of the industry. So
there's a gap in the market, Gary. It has to be filled.
Exactly, there's a gap in the market. So we're going to exploit that gap in the market today by giving you all of the secrets. And Nicola's going to shed some light on those secrets.
Yeah. Okay. So PCOS, or polycystic ovarian syndrome, it's a really common but complex endocrine disorder that affects about 1 in 10 women in Ireland or in the Western world. It's something that goes undiagnosed for a long time, and it's something that's underdiagnosed in a lot of women as well. And it's one of the leading causes of infertility in the Western world too. So it's a multi-system issue that can be characterized through 3 kind of main criteria. Now, these criteria are heavily debated and it's not really all inclusive, but it's mainly characterized by menstrual cycle irregularities. So whether that's irregular periods, whether that's anovulatory cycles, an increase in androgens as well. So that's kind of the male sex hormones. This would manifest in things like, male kind of pattern hair, so that's on kind of your chin, back, chest, etc., oily skin. And then finally, polycystic ovaries. So this is where you'll have a number of ovaries on the cysts, a number of cysts on your ovaries, excuse me. But the thing is that many women have cysts on their ovaries and don't necessarily have PCOS. And then there's women with PCOS that might not fit the criteria of having polycystic ovaries as well. So that's something that's generally diagnosed from an ultrasound, and it's not just classified or diagnosed with having cysts on your ovaries. It's dependent on the amount and the size, etc. Now, those criteria don't necessarily encompass all of PCOS. You have a lot of other things going on, like reduced insulin sensitivity. A lot of women will be suffering with obesity and metabolic syndromes like type 2 diabetes, hypertension, dyslipidemia. There's a lot of like long-term consequences of PCOS as well, like the before mentioned metabolic syndromes. You can have issues kind of with bone health. You can have issues kind of with endometrial hyperplasia. Mood disturbances are really common, like anxiety and depression. It's hard to know whether that's kind of a chicken or the egg scenario. It's likely that they both kind of influence each other. And then fertility then is a big one and a big issue for a lot of women as well. I suppose the important thing with PCOS is to talk to your doctor about it. There's a lot of other syndromes and disorders that can mimic PCOS, and it's important to rule them out as well. So it's not something you want to go self-diagnosing yourself. You need to rule out kind of thyroid issues, issues with the pituitary like hyperprolactinemia, and then other issues that can mimic an increase in androgens as well. So whether that's Cushing's syndrome or congenital adrenal hyperplasia. So those need to be kind of discussed with your doctor first and foremost.
Yeah, and this is really important to just start off by saying that, first of all, I'm an idiot. I'm not a doctor. Gary is like 3/4 of a doctor. Nicola is a doctor. But even listening to all of us, you're going to have to go to a doctor to get a diagnosis of this. You can't just do this thing that you see. It's very prevalent on social media or forums, especially around like say thyroid issues. People go, yeah, I think I have a thyroid issue, and they never go to their doctor to get it diagnosed. And people will say like, I think I might have PCOS, or I have something going on there, and never go to their doctor and get it diagnosed or get help. So look, we can't diagnose you via a podcast. You have to go to your doctor. You have to find out what's going on. It is actually really important to dig a little bit deeper with this stuff and actually effectively like see what's under the hood, what's going on, what's going on with your health, because it kind of seems like one of these things where people will just kind of go, oh yeah, like it's PCOS, it's kind of annoying to have, but YOLO, right? But in reality, like it's actually associated with a lot of risks, a lot of long-term risks. And you might not be thinking in your 20s, you might be like, like it's really annoying. Maybe you'd be like, oh, fat loss is a little bit harder. That's about it. That's the extent. Now, obviously, that I'm being a little bit facetious here, but you're just like, oh, fat loss, that's the thing. Like it's actually something that you really need to be thinking about, because maybe later on in your life, you're like, I want to have kids. It potentially affects that. Later on in your life, you're like, okay, well, actually, there's a higher degree of like heart disease in my family, and now you have another thing that's potentially increasing the risk of heart disease. Or maybe there's like metabolic syndrome related diseases in your family, and you have another thing that's increasing your risk of metabolic syndrome. So it is something that is really important to pay attention to. So before you listen to the rest of this podcast, if you're like, yeah, maybe actually PCOS, that's me, and you haven't gone to the doctor to get a diagnosis or investigate this further, that is your first step, right? We're going to go under the assumption that right now, if you're listening to this and you're like, oh, I have PCOS, it's because you've been diagnosed with PCOS. So all of the stuff, the practical stuff or whatever that we talk about later on, we're going under the assumption that you have an actual like diagnosis of this stuff, or you're just interested in learning about this stuff. Yeah. But one of the things I would like to also bring up is that in athletes, it seems that PCOS is a bit of an advantage. Now, this is actually kind of like poorly researched, because obviously with athletes, you don't know what the fuck is going on. Loads of athletes take drugs. You can't really be like, oh, it's the PCOS, or whatever. Like, we don't know, right? But you could argue that it is a bit of an advantage in certain sports, at least, right? Because you have this like hyperandrogen, thing going on where you're like, okay, you got more androgens than the average woman. So all of a sudden you have, we'll call it quote unquote, better response to training. You have potentially abilities to handle, more intensity. You have those like risk-taking things that we talked about before about, testosterone. It's like, you're more willing to do things that a man is willing to do. And that can be, first of all, advantage. I was actually reading a lot of research for this as well about like women with PCOS in the workplace as well. And they seem to get higher pay because they reckon it's because they're more assertive. They're able to go like, I'm going to actually like ask for that money or that kind of stuff. So it's not like PCOS doesn't have certain advantages in certain subpopulations, but that doesn't mean that we have to just kind of go, oh yeah, like this is just something to not think about it. But I'm interested to hear either of your opinions on that, or your thoughts on that. I shouldn't say opinions, it's your thoughts.
Yeah, that's an interesting one. And I think like thinking back to the subtypes of PCOS, like you're saying, you can, for a diagnosis, you're looking to have kind of two of the three. So whether it's the kind of menstrual cycle irregularities, the increase in androgens, and the polycystic ovary. So you can have two of them and still be diagnosed with PCOS. But if you're just say an athlete and you're someone who has the increase in androgens, like absolutely that can be an advantage. But if you also have menstrual cycle irregularities, and we were spoke in the last podcast about amenorrhea and the knock-on effects of having kind of low estrogen on bone health, etc. If you're an athlete and your hormones are flatlined and you get a stress fracture or something, that's completely knocking you out of the water of kind of your, athletic ability. So if you're someone has the increase in androgens, maybe polycystic ovaries, maybe you're onto a win, but maybe not if you've been.
That's actually interesting as well, because I was reading another, like a few papers. I think it was like between 20 and 40% of women who present with amenorrhea in that sporting context do also have PCOS. So it's like, you could have a winner in terms of, you're like, all right, I have the androgens here, to the testosterone or whatever to help with my sport. Maybe, I'm able to get stronger and, I have this little slightly increased reaction time, whatever it is. But now you've also got amenorrhea, and the higher testosterone helps you in the first few months, years of your training, but all of a sudden you're a few years in and you're getting stress fractures, or you've got all these other things going on that lead to you having a shorter career. So it is interesting. But anyway, look, we won't talk about subpopulations, because the vast majority of the people listening to this are probably not in a subpopulation. You might be like, all right, well, people who go to the gym, maybe they're part of the subpopulation of athletes, but in reality, like, it's probably just 1 in 10 that are listening to this, like the average statistic. I don't know. You did kind of, we're going to go into the symptoms there. We did kind of touch on a lot of the symptoms. I don't know if you want to go into any more depth on any of those.
Yeah, so like you're saying, there's loads of different subtypes, and kind of PCOS is a collection of symptoms. And because of the different subtypes, it's going to present differently for a lot of women. And I suppose what's unfortunate about it is there's a huge delayed diagnosis for a lot of young women and girls. And that partly comes back to, when you're kind of 15, 16, and, you're breaking out and all this acne. Often the first port of call is to go on the pill. And what we see, and it's an issue with a lot of my clients, is that, they put on the pill at like, 14, 15, and again, nothing to do with, contraception. And then, it's suddenly 8 years later and they're like, I don't have a clue what my periods are like. They might be someone who suffers with ovarian cysts, but it's never really been investigated. They don't necessarily fit the criteria of PCOS because they've been on the pill for years. Now they're in, long-term relationships. They don't want to come off the pill. And you're just kind of in this kind of conundrum where you're like, do I have this? Do I not? If I come off the pill, am I going to have these crazy periods? Am I going to be, infertile? It can be a huge cause of concern for a lot of women. So like we're saying, we kind of went through a lot of the symptoms already, but it is going to look very different to a lot of people. So like we were saying, maybe the absence of a period, the irregular periods, the excessive hair growth, kind of cysts. And again, cysts are really normal, and most women will have kind of a physiological ovarian cyst, at one stage that generally will just resolve on its own and won't cause many issues. And it doesn't necessarily mean you have PCOS. You've weight gain. There's also the lean type of PCOS, which I'm sure we'll get onto. So it's not really, it's not something that kind of everyone doesn't fit into the one box with PCOS, which again, just makes the diagnosis a lot messier.
Yeah, and I've seen that a lot in clients as well, where they'll come in and go, all right, well, I've been on the pill since I was 13, 14, 15. Like basically they started having periods and they're almost straight onto the pill, and like, that's fair enough. That has something to be discussed with your doctor, etc. Right. But they get to that, early 20s age, maybe even late 20s, and they're kind of going, I don't know what my quote unquote normal cycle is like, and that's in just, the general population. But you can imagine then if you have something else going on, such as PCOS, and you're kind of going, well, I don't know, I've had all these symptoms and I'm kind of going, maybe it's because of this, how do you do the experiment? What do you do? Oh, I'm just going to come off the pill and hope that everything, comes back to normal, or it's like normal if you've always been on the pill, you don't know what your normal is, you're like, I'm just going to see what happens. That can take 6 months to kind of really get everything going, but even longer, even in some cases. So it's very hard to really dial in. And then you also have to deal with, this is not here's the exact criteria and here's the exact symptom list. This is a very, or at least it seems, messy kind of thing where it's like, oh, you could have this and maybe this and these symptoms here and this could be it. And then you're kind of chasing your tail a lot of the time going, well, I don't know what's going on. So this is, again, you have to talk to this stuff with your doctor. I can't even speak today. You have to talk about this stuff with your doctor, because they're going to be able to do further investigation. They're going to be able to do an ultrasound and actually look at your ovaries and stuff. You're not going to just go, I think I actually have a cyst on my ovary. You're not going to necessarily feel that and go, yeah, that's exactly what's going on, So I would recommend the people, if they think they have this going on, PCOS, talk to your doctor. I know a lot of people are hesitant to talk to their doctor regardless of the population. They're kind of like, oh, well, the last time I went to the doctor, they just told me to lose weight, or, last time I went to the doctor, they just said this. And you're kind of like, I understand that it can be a, annoying thing to do, frustrating thing to do. It's somewhat even psychologically damaging thing to do. If you go to your doctor and you're dealing with, PCOS, and you have weight gain that you're not happy about, and their only recommendation is, yeah, it's probably just because, you've gained weight or whatever. That's obviously not helpful. So I understand that perspective, but, especially in a lot of the Western world countries, at least, you can go to a different doctor. You can go and go, all right, that doctor, they're just not a good doctor for you. They might be great at other things, but you can go to a different GP, in a lot of cases. Obviously, look, if you live in an area and there's one GP for, fucking hundreds of miles, you're kind of fucked. But in a lot of cases, you can go to someone else, talk to someone, find someone that will actually help you.
Yeah, absolutely.
100%. Right. So we could talk about what causes it, and I'd love to have this nice, like, beautiful explanation of this is exactly what causes PCOS. This is the entire, like, start to finish. Avoid these things. Make sure you don't do these things if you don't want to have PCOS or you don't want your children to have PCOS. However, we don't have a fucking clue, right? There's a lot, like, again, I've read a lot of research on this stuff, and there's a lot of different theories. There's a lot of, like, oh, it's potentially the, uterine environment. This could be the reason that, it seems to run in families. Could be genetic related as well, which would also explain why it runs in families. But then also you just have all these different things going on. For example, like if people get IVF or different things like that, any kind of assisted fertility seems to increase the risk of PCOS in some studies, but not in others. So you're kind of going, like, I don't know what the actual cause of this is. And luckily and unluckily as well, we don't necessarily need to do that, at least for the stuff that we want to talk about, right? We don't need to know what causes this. I'm sure both of you have kind of theory on, like, maybe I actually think it's a bit more, it's probably this, or maybe these two things, these are the biggest, prevalent things that the causes, but we really don't know, But again, we don't need to know, because what we actually care about is, like, what can we actually do about this stuff, right? What can we do about PCOS? Because that's probably what the vast majority of people actually care about. Like, if you go on any of these forums, like, you type in, like, PCOS and just type in, like, Reddit or whatever, right? And, like, you see it, people just want to know how to deal with their symptoms. People want to know how to deal with like, all the things that are going on. They want to deal with, oh, well, maybe I actually want to have kids in a few years. How do I make sure that my fertility is as good as it can be? Or they're like, all right, actually, I don't like this weight gain, or I don't like the increased risk of heart disease. I don't think anyone really likes that. Different things. They're kind of looking for a more practical way to manage this stuff. They're kind of going, right, I have these symptoms, I have these issues, it's related to this PCOS. What is the checklist? How do I get going with this stuff, right? So before we really get stuck into the kind of what can you do about it, right? The first question I suppose you have to ask, and again, both of you can chime in here, can you cure PCOS, right? Because that's obviously the first thing. You're going to go, all right, I've got this diagnosis from my doctor. Is this something that's quote unquote curable? Like, if you go into the doctor and you're like, I don't know, they tell you have some sort of illness, like, you're going to go, whoa, is that curable? Is that something that can be fixed, gone forever? Or is it something that I'm just going to have to manage? Like, I'm going to have to manage the symptoms for the rest of my life. So what's the story there?
So I think for this one, no, is I suppose the easy and short answer, but you can absolutely manage symptoms, and it just depends what symptoms and what exact, not even symptoms, in terms of infertility, what you're trying to manage. Like, it is, like you're saying, a big cause of infertility, but that can also be helped and reversed as well. So not necessarily cured, but absolutely it can be managed.
What about your thoughts, Gary? Do you think it can be cured?
Yeah, I mean, no. Yeah, no. I agree. I agree with Nicola. I think that there's a certain element of reversibility or remission, one might say. It's kind of a little bit like the type 2 diabetes discussion. Like, can you entirely cure it? Probably not. Can you put it into remission? Maybe. But it depends on the person's baseline. So, for example, if we were to look at the two phenotypes of obese versus lean PCOS, the person with obese PCOS has that additional window of opportunity where weight loss is likely to improve a lot of the elements of PCOS, whereas the person who's already lean with PCOS might have a little bit less room for improvement there already. So it depends on where you're starting. There is research to show that you can absolutely improve a lot of the syndromic features of PCOS, often with weight loss and improvements in lifestyle and all the other measures that we'll get onto. So I would view it as something that you're maybe trying to reduce the symptoms of, reduce the features of, potentially put into remission, but not necessarily something that you're looking for a cure in relation to.
That's fantastic. And because you brought it up there, and we did talk about it earlier on in terms of there being different subtypes, what's the story between this lean PCOS and overweight PCOS? I've never heard of those terms. Tell me about them.
Yeah.
Go ahead, Nicola. Yeah.
No, you go on.
I was just going to say that it's sort of a little bit like the evolution in the understanding of type 2 diabetes, I guess, because and these are related in some sense, because a lot of the ways or the immediate image that probably comes to your head when you think of type 2 diabetes is probably someone who's overweight. That's often, and they are tightly related for sure. But you can have type 2 diabetes at relatively low BMIs. You could have a BMI in the healthy range and have type 2 diabetes. And it sort of depends on the features of that phenotype. So for example, adipose tissue distribution. If you have a lot of central adiposity, a lot of body fat around your abdomen, particularly visceral adiposity around your organs, that can predispose you to type 2 diabetes and propagate that cycle of the pathogenesis. And it's sort of similar in PCOS, where there's a spectrum of the individual who's quite lean, but they still might have a higher level of visceral adiposity. And then the person who is overtly obese, I guess you could say, in the sense that they have an obese BMI and they fit the more classical description of having excess body fat. So you can absolutely have PCOS while being in a healthy BMI range, for sure. You can even be quite lean with it. But I think the vast majority would fit into the category of having higher levels of adipose tissue. It's just that there are, again, exceptions to that rule, similar to type 2 diabetes.
Trying to add to that?
Not really, exactly like Gary was saying. It's like a multifactorial disease, and we don't fit neatly into these boxes, and that's why you see such a range and such a variation between women.
100%, and that makes recommendations hard, right? So when we're talking about this stuff, when we go, what can you do about this? You have to realize that we're talking in generalities. Like, yeah, we're going to qualify some of this stuff and go, maybe if you have this going on, you think about this. But in reality, you're kind of in a position where you do have to do a little bit of self-experimentation. You have to kind of go, right, this is the general recommendation for someone with PCOS. How does that apply to me? Do I have this lean PCOS phenotype? Do I have this overweight PCOS phenotype? Do I have this going on? Like, what are the symptom or the criteria do I have? Like, you have to kind of dig a little bit deeper with that stuff. Now, having said that, a lot of the stuff we're going to talk about, it does kind of apply across the board, we'll say. Like, a lot of the things that you can do for PCOS are just generally good diet health practices. The thing about it is, if you have PCOS, you just have to be more on top of this stuff, right? Like, if you're just a quote unquote healthy population, like, you can kind of go, I can get away with doing this thing. I can get away with doing this thing. It doesn't really, impact me too much. Whereas if you have PCOS, you kind of have to stay on top of this stuff a little bit more than the regular person, than the quote unquote normal person does, right? So that is one of those things that, again, it's unfortunate. I wish the world was completely equal and we didn't have these like populations where you're like, you actually need to be more attentive and you're going to have a harder time with it. Like, I wish that wasn't the case, but unfortunately, PCOS is just one of those like syndromes or diseases that you do kind of just get the shit end of the stick. Where you're like, right, you have to, pay more attention to this stuff. You're probably going to have a harder time with it. And that's just the way it is, and one of the things that I say to a lot of my clients that do have PCOS, or in the past, I'm like, look, you can't compare yourself to someone else. Like, I say that to a lot of clients in general, where I'm like, a comparison is a thief of joy, because you don't know what else is going on in their life. But if you have PCOS, like, you can't compare yourself to your friend who's like, oh yeah, like I eat like crap and like I do a little bit of exercise and everything's all good. I'm able to maintain the body that I want, etc. And you're kind of going, well, that's fucking unfair, because I'm really on top of this stuff. I'm going out, I'm trying to do the exercise, I'm trying to do like stick to a diet and all this kind of stuff, and you're not getting the results that you want, right? And obviously that's me talking about that in the context of, body composition or changing your physique or whatever, but also there are health ramifications as well that you're just going to have to deal with, that this other person that, I can just, free live here and I don't have to think about this stuff, that they just don't have to think about, right? But anyway, where do we start with this, Nicola? So let's say, client starts with you, they come to you, they're like, yeah, look, I need help. I listen to your podcast on this stuff, but they're coming to you and they're going, I just need help. I need someone to help me dial this stuff in. I need someone to help me with my PCOS. Maybe they've got a new diagnosis of it. Maybe they've had it diagnosed for a couple of years, but they're still struggling to figure everything out. Like, what's the starting point, right? So where do we start with all of this stuff? Now, obviously, look, the same with everything. We can go down a million avenues from the start, but where do you think is the biggest kind of, lever to pull?
Yeah, so even before getting into that, a client that started with me only last week, was diagnosed with PCOS about 10 years ago, and when working with an endocrinologist, was put on medications for kind of weight loss, it didn't help, just kind of gave her GI issues, but she's never received any dietary advice. Which is really kind of unfortunate and upsetting. And it kind of just links back to, us thinking that, we need some kind of supplement or some medication to solve this, when actually lifestyle and dietary advice for PCOS goes a long way. So between nutrition, training, stress management and sleep, we can make huge progress. And like you were saying, like a lot of the things that we're going to be going through are generally things that we would recommend for a client without PCOS anyway. A lot of this stuff is like generally, good dietary practice. However, there are going to be things that just affect women with PCOS more than women without. So, we'll be talking about, the effect of like carbohydrates, protein, on kind of insulin sensitivity and that sort of thing. But like you're saying, just going back to a lot of these things are just generally good dietary practices. But yeah, where do we start? And
I suppose before we get into that, we should actually really just we should actually just clarify what we're trying to do with this, what symptoms are we trying to manage? Because the way we're going to talk about it is there's a few things like, the big ticket items we'll say that we're trying to deal with. One is this issue around carbs, which you can go into in a second. One is this issue around like androgens, and obviously you'll see in a second that it is related. But what else are we kind of looking at? Because they're kind of the two big ones that seem to be brought up a lot. People are kind of going, I just don't know what to do with my carbs. I hear insulin. I just don't know what the story is there. And then I also have this like hyperandrogenism. I have too many of these male hormones, Is that all we're dealing with? Or like, what are we trying to manage when we're trying to do different things with the diet, the training, etc.?
Yeah, so I suppose we're looking at what the starting point is for the person and what actually affects them. Like we were saying, there's the symptoms and the difficulties range from woman to woman. So, it isn't, we can't just make kind of blanket recommendations. We need to kind of assess the person that's in front of us. And, even with, carb intake, like, some people are going to be more insulin sensitive or more insulin insensitive. So it's going to vary so much from person to person as well. Someone with, a lot of the focus with PCOS is kind of lose weight. But, if we have someone in front of us kind of with lean PCOS that doesn't necessarily need to lose weight, kind of what do we do then? We don't need to so much have the focus on weight loss. And it might just be not only focusing on, carb intake kind of and protein, fats, whatever. We're also looking at kind of stress regulation and how kind of food kind of, fits into that, appetite regulation, that sort of thing.
100%. And that is really important, that like, this is not, again, one symptom list, it's not like here's the top 3 things. It's going to be different for everyone, right? But I suppose we'll start on the calories, right? Because that's, this is the thing that people are going to go, oh, well, what do I do here? Like, where should I set my calories? Or, I see that I should lose weight. I don't know how I should do that. Because look, this is hard for, again, someone in this, free living, normal population. People struggle with weight loss, right? So if you have this overweight PCOS phenotype, like, you're probably going to struggle with weight loss more than the average person, and a lot of the things that you can do for this, we've talked about before in terms of, just generally losing weight. But one of the major things that I find with people that I've coached with PCOS, like, you do have to go a little bit slower, right? And that's a bit annoying because you're probably going to find weight loss a little bit harder, right? If you have PCOS, and then being told, oh, you just have to be slower, more patient. It's a bit frustrating, right? But it tends to lead to better results. It tends to lead to better results in, again, the general population, but especially with PCOS. Like if you just take it a little bit slower, so rather than going into this like 500,000 calorie deficit, trying to burn 1 million extra calories per day, if you just go a little bit slower and go, all right, I'm actually just going to eat a little bit less, or I'm going to be a little bit more active. Like that seems to really make the world a difference with this stuff. Now, obviously, that does mean that it's going to probably take longer. You know, it's probably going to take, like, if you're like, all right, my friend can lose X amount of pounds in 12 weeks, I'm going to try to do the same. And you're like, no, it's actually probably going to take you 24 weeks to 30 weeks to do that. That's frustrating in and of itself. However, it does seem to, at least in my experience, it does seem to get us better results longer term. You know, like you'll have clients say at the end of it going, wow, I've always struggled to lose weight, or I've always struggled to really get the results that I wanted. And it's because they have PCOS, again, a certain phenotype of PCOS. And now we're kind of going, all right, that means that we shouldn't be working against that. We should kind of be working with it and kind of go, right, that means that we just need to go a little bit slower with this stuff. But would you guys agree with that?
Yeah, definitely. And I think, you know, for a lot of women with PCOS, just say their starting point, they might be coming to you kind of the most overweight that they've ever been. And so they might be looking at losing kind of 30 plus kg, you know, depending on where they're starting. But that is a huge amount of weight. So even just letting them know that a nice, like a good kind of starting point is just like a 5% weight loss, and that's shown to have, you know, like improved fertility, menstrual cycle regulation. So, you know, instead of having this kind of absolute mountains, you're telling someone to take things slow. You know, they're like, no, I need to lose like 30 kg, but actually just kind of aiming for that 5% weight loss actually has huge benefits attached to it as well.
Yeah, and especially if you are in that kind of overweight PCOS like phenotype, like losing weight improves insulin sensitivity in a lot of cases, not always. There's just some specific cases where it potentially wouldn't, but losing weight seems to improve insulin sensitivity, which then has knock-on effects for all the other stuff. So it does actually kind of become a little bit easier. But one of the things that you will find difficult about this, and we kind of touched on it in the last podcast, is if you're in a calorie deficit, the risk of amenorrhea does obviously go up. You know, obviously, if you have a more extreme calorie deficit, that's an even higher risk, you know? So what I often do, and this is something that I'd be interested in both of your opinion on this, what I often do is I'll take things in like chunks. We might diet for 8 weeks, and then we're like, right, we're taking a 2-week maintenance period here, you know? I generally do that with most of my clients. I go, right, we've defined the period of time that we're dieting for, and then we're going to do a maintenance period. But for clients with PCOS, I'm generally thinking like, you know, 8 weeks, that's kind of the max. And I'm like, that's fat loss, unless everything's going perfectly fine and, you know, there's absolutely no reason to kind of stop it. But other than that, I'm kind of like, right, 8 weeks, then we're doing a little bit of a diet break. So if you want to call it that, and we're eating at maintenance. And the reason I do that is twofold. First of all, like in my experience, at least, cravings can get a little bit higher in women that have PCOS. They can find that it's a little bit harder to stick to the diet for a longer period of time, you know? So I'm like, right, we're going to just have a definitive block here of 8 weeks, 4 weeks. It could literally be 2 weeks, 2 weeks on, 1 week off kind of job, you know? So whatever method or, you know, protocol you think works the best for you, that's when you can use. But I like this 8 weeks, then kind of 2 weeks off or at maintenance. And that kind of does two things. First of all, it helps with all those cravings. It helps with all those kind of metabolic adaptations that have potentially started to really kick in to the diet. But then also it helps teach people that, oh, I can actually eat at maintenance and I can maintain my weight. Because this is actually so important in just a general sense, because a lot of people will think that, oh, what I have to do to lose weight is what I have to do for the rest of my life, you know? And that's just not the case, you know? Like there's going to be a period of time where you're going to switch the diet focus and you just want to maintain the results that you've gotten, right? So let's practice that. Let's actually practice eating more food, because that can be something that, in my experience at least, is kind of psychologically a little bit hard for most people, but especially if you have PCOS. Because let's assume, right, we're doing this 8 weeks of dieting here and we're getting great results. You find, okay, I'm losing some weight. I'm feeling a little bit healthier. I'm feeling like things are on the right track. And then I say, you know what, actually, we're going to eat more calories now. You know, that can, like, psychologically, that can be a little bit hard to do, even though you might want to actually eat more, because you're kind of like, well, everything's going it's going good right now. Why would I want to mess with the formula? Well, like, I've struggled with this stuff for the last 5, 10, 15 years, whatever it is. And now we've really cracked it. No, let's just keep going with that. And it can be hard to explain or like get people to have that buy-in and go, this is actually better long-term. It's actually better long-term to take these little breaks, even though you think it might interrupt the momentum that you have. But what are your guys' thoughts on that?
Yeah, I think it's a reasonable approach. I haven't coached that many people with PCOS, so I don't have enough like practical experience to know which works best. But I do like the overall philosophy, and I think particularly here where someone might potentially have a lot of weight to lose, like Nicola said, let's say someone has 30 kilos of excess body fat and they want to lose all that. Firstly, reminding them that you only need about a 5% decrease to see actual meaningful outcomes. And I suppose another tangent on that as well is making sure that those outcomes are actually made clear to the person, because someone might come into this with their understanding of PCOS being very loose and their concerns, particularly when they're quite young, being solely cosmetic, that they might say, look, I just want to lose the weight, I want to look better, not appreciating the effects of, anovulation, long-term infertility, etc. So making sure that the person is aware of the fertility and cardiometabolic risk considerations and making that an outcome can support someone on that journey then, because they're thinking a little bit more long-term, I think. And then obviously reinforcing that, right, if this is a 5% decrease in body weight that we're looking for, here's what that looks like on paper. Okay, so let's say it's 4 kilos, whatever, that we have to lose. We're going to break that down, 2 kilos in this 8-week period, nice and slow, and another 2 kilos in the next 8-week period. That doesn't sound like much at all, but over time, those differences can begin to add up, especially if someone is in it for the long run. And when you have those breaks as well, it's sort of like a bit of a checkpoint that you reach along the way, where if you diet for 8 weeks, you've learned certain skills during that period of time. So what you could do is then review with the person or review with yourself, what have I learned during this period of time? What worked well? What didn't work well? And then as you go into your next 8-week block of dieting, you make a couple of changes, see what worked well, what didn't work well. And over time, you're going through this iterative process of developing a dietary structure that's more appropriate for you. And then that also gives you the time to foster what might be your long-term approach, as opposed to solely this short-term diet.
Yeah.
And one of the things that I often do with that as well is I kind of plan out the weight loss. I actually don't like doing this in general, but what I'll do, again, assuming we're trying to lose weight here, but I'll kind of go, right, we want to be in the range of 0.5 to 1% body weight drop per week, right? Now, obviously, that's not going to happen every single week, but the reason I kind of plan that out is because it gets people's head straight, going like, oh, that's what I'm actually looking for. It's not this like, I'm going to drop 5% this week, because like, yeah, that can happen the first week. You literally go on a lower carb diet, you drop calories, you maybe, I don't know, drop a load of fiber or something, and all of a sudden you're like, all right, look, I dropped 5 kilos. That's not representative of actual fat loss, right? But look, if we're looking at that kind of 0.5 to 1% body weight drop per week, like it's a nice range where you're not being too aggressive. Like 0.5, it's almost unnoticeable, like in terms of the calorie deficit per day to get that. Now, there are a few issues. Obviously, again, we've talked about them in previous episodes, where if you're a woman, you might have this fluctuating weight week to week. Now, you might not, if you have PCOS, you might be on the pill, for example, and there might be less fluctuation. You might be doing the pill with no breaks, for example, and you might have less fluctuation, but still there's going to be some fluctuation in your weight. So we don't care too much about, oh, you lost only 0.45% body weight this week, you're gonna have to drop more calories or whatever. Like we don't care about that. We're just looking for that average, that trend in the right direction at a nice slow rate, right? And the reason I often plan this stuff out is because it actually helps people think longer term, in terms of like, you get this client who comes to you and they're like, I need to lose 30 kilos. That's where I want to be at. That's where I feel at my best health, etc. And like, plan that out and go, well, this is how long it's going to take. This is what it's going to look like if we're going to really be patient with this stuff. If we're really going to try to get you to that position in a healthy way, while also potentially improving the PCOS. Because what we don't want to have happen, and this is one of those things which is actually really hard, and you've got this like razor thin margin here with this stuff. What you don't want to have happen is, yeah, you'd lose a load of weight, but all of a sudden now you're really amenorrheic. You've really dug a hole with that stuff, and you've got all the side effects of that and all the issues with that. Like, you don't want to just be like, all right, yeah, I'm going to, cure my PCOS here, quote unquote cure. I'm going to fix all of the issues here. I'm going to drop a load of weight. I'm going to get the physique that I want. And all of a sudden, yeah, you're 12 weeks in, but you're in a way bigger like recovery deficit, a way bigger hole with regard to this amenorrhea side of things. And now that's becoming a bigger issue for you. And if you already potentially have reduced fertility and you already have a condition that potentially increases your risk of amenorrhea or oligomenorrhea, like, we don't want to exacerbate that stuff. However, having said that, like, PCOS is one of those ones where I don't mind as much if we do have some amenorrhea going on, right? But we have to be strategic with it. And that sounds really like counter to our health focus. But what I mean by that is, if we're dieting and we're getting really good outcomes with that stuff, right? We're really like, all right, we're going to be dieting for the next 16 weeks, for example, or whatever, the next 20 weeks. Like, if during that time period we have some amenorrhea occur, it's just like, right, it happens. There's nothing we can do about it. We're in a calorie deficit. We're trying to be, careful with this stuff. We're trying to be low and slow with this stuff. We're not going into an aggressive deficit. Like, that's fine. I can live with that if we're in this kind of 20-week period. Once we have a plan of action after that, that kind of goes, right, how are we dealing with that after, right? Are we increasing calories? How are we doing that? And you can go back and listen to our previous episode on amenorrhea and kind of, figure stuff out there. But the reason I bring that up is because I know a lot of people will try to deal with their PCOS. They'll try to, get some fat loss or weight loss or whatever, really improve this stuff. And then all of a sudden they'll start noticing they get amenorrhea, right? And they could be doing everything right. They could be doing absolutely everything to the T. They're not being too aggressive with their calorie deficit. They're not doing anything like, excessive, but they still encounter amenorrhea. They still get the issues around that. And I don't want people to be discouraged and think, oh, I'm doing something absolutely awful here. I'm like, I've ruined it. I'm not doing this right. Like, if you have a condition that increases your risk of amenorrhea, like, it is one of those things where, unfortunately, you just have a higher risk of amenorrhea. So if you do stuff that increases your risk of amenorrhea, you're now at a higher risk, but that's okay in the short term. Like, obviously the ideal scenario is that it doesn't occur, but look, it happens. But that's okay in the short term, as long as we have a plan of action after that. How do we recover that normal cycle? How do we get to a position where you are, back to quote unquote normal, or this kind of baseline, but I'm interested again to hear your thoughts. And actually, before I forget it, one thing that I do also often do is, when we're talking about calories, is I make sure that we do spread those out throughout the day, because like we discussed in that amenorrhea podcast, we don't want to do stuff like intermittent fasting. We don't want to do stuff like, oh, I'm just going to skip meals in the day, because you will read that on forums and stuff being like, oh, intermittent fasting really helps with insulin sensitivity. You'll hear people say that stuff, right? And maybe potentially in certain circumstances that is the case, but we're not going to use that tool to improve insulin sensitivity, right? The tool we're going to use to improve insulin sensitivity in most cases, especially from what we can talk about, and well, Nicola, you can talk about other stuff, but in terms of what we can talk about as like coaches or whatever, we're going to use a calorie deficit, so that'll improve insulin sensitivity. We're going to use weight loss, and then we're potentially maybe focusing on a little bit of carb intake. We're going to talk about that in a second. But what I'm not doing is I'm not having large periods of the day where we have low energy availability, because that also increases your risk of amenorrhea. So we don't want to do all of these things. Like, I always think of it like a dimmer switch, like, you don't want to just turn the dial all the way up. If you're already starting at half the dial because you have PCOS, you have an increased risk of amenorrhea, you're already at half. Yeah. So we don't want to just go, oh, here's this other thing that is normally a quarter turn. For you, that's a 3/4 of the way around now, so we don't want that to have happen, right? But I'm interested to hear your thoughts on that, Nicola, especially.
Yeah, it's funny. I think I mentioned intermittent fasting every episode and its like effect on hormonal disruption. And that's purely because when I started coaching, I think I championed it for everyone. I was like, it's so good. It was like the big thing in fitness back in the day, so I'm like cringing thinking back to that. But so I always mention it now. And that's a huge thing as well, like that you will see with women is pushing out their meals to later in the day. And what we know, not only kind of for PCOS, but again, for the general population, actually kind of front loading your calorie intake or your energy intake more towards the start of the day can have improvements, you know, in insulin sensitivity, in you know, kind of hormonal regulating kind of your menstrual cycle, that sort of thing, and kind of having it more in touch with your circadian rhythm. So having more calories at the start of the day and not having the bulk more towards the end, that can be really helpful. And like, we need to, you know, not forget that kind of going, you know, without food for long periods can increase our cortisol. Having that intermittent fasting to the start of the day, if you're training at the start of the day, you know, you're fasted and you're training, just again, that kind of stress hormone can go through the roof, and again cause that hormonal disruption as well. You know, reducing your calories, again, that is an energy deficit, which is a stress state. So we need to, you know, not forget that as well, that there can be, you know, a lot going on. So really not only monitoring your energy intake, but what proportion of calories you're having, when are you leaving big gaps in the day, and then obviously the composition of meals as well. And what I say to, you know, clients is like, we can get into like really the kind of nitty gritty of, you know, how many carbs you're having, how many fats you're having, you know, we can have it down to a T, but we really need to sort out some of the like low hanging fruit first. And that is the fact that you're leaving like 8 hours in the day without food, you know. So just making sure that you are having, you know, that having lunch, essentially, that's the biggest one that people call, you know.
Or even breakfast as well. Like you see,
Yeah.
it's lunch and breakfast. They're the two ones that are kind of like, oh, like,
Yeah.
you know, it's either like, I'll have a snack, I'll have a little small bite. Now we're talking here like 50 calories for lunch, or breakfast. They're just like, oh, like, no, I'll start later in the day. And that can be fine. That's the thing. This is not like oh, you could never do this. We never recommend that. Like, I have clients that intermittent fast, women as well, you know, and it just fits the schedule. It's perfectly fine, right? But when we're talking about PCOS here, or we're talking about trying to do everything in our power to make sure that we get like symptom resolution or get a better outcome, like, we're not going to do these things that we know potentially impact negatively on those outcomes. But I'm interested to hear your thoughts, Gary. Do you ever use intermittent fasting with any PCOS, or would you recommend it?
Not particularly, really. I mean, like, I don't generally recommend intermittent fasting as a rule. Like, it's not something I regularly prescribe for people. Like, I'll give it to them as a loose option, you know, like, all right, you're having difficulty controlling your intake in the evening. Maybe they have a large meal with their family or something. I might get them to push breakfast back a little bit and keep it a bit lighter or something. But I'm very rarely encouraging people to engage in like prolonged fasting beyond 14, 16 hours. You know, generally I like to encourage people, regardless of their baseline state of health, to develop an eating pattern that they're going to be able to maintain, that fits in with a normal social life, that fits in with their normal family life, etc. So that's generally what I'm encouraging in the vast majority of people. If I had a client with PCOS, it wouldn't be any different. The only time that I will encourage a bit more of a fasting type of approach would be in that person who's having a bit of difficulty with adherence and seems to find fasting to be superior. If that was the only way that someone with PCOS and obesity was able to maintain a deficit, it might be a net positive. It just depends on the individual context. And one thing that is important as well, you mentioned it in terms of the amenorrhea discussion. You can have coexisting PCOS or just polycystic ovaries and functional hypothalamic amenorrhea, so from low energy availability. That's really important to distinguish, to identify. That's why you need a good doctor that's familiar with PCOS, because you could just look at the presentation of amenorrhea and identify one or the other. And the sad thing about this is that you can somehow, if you have both of these things, so with functional hypothalamic amenorrhea, there's a higher rate of PCOS within that group and polycystic ovaries within that group. And one of the things that you get from PCOS that might be a bit of a benefit is stronger bones. So you get those androgens and you get an increase or decreased risk of bone mineral density loss and fracture as a result. However, functional hypothalamic amenorrhea basically wipes that out. So you're basically getting the worst of both worlds together if you have these coexisting. And that's one of the reasons, again, it's just important to that your doctor does a complete assessment and that you're dealing with that with them, because there are different things that can be measured as part of the workup here. It's not just your estrogen, progesterone, LH, FSH. You're also looking at things like obviously the androgens, anti-Müllerian hormone, and the ultrasound, like we mentioned previously. So a lot of different elements of the workup there. So again, see your doctor, because that's a difficult enough one to distinguish, and it's probably something that even like if you go to your GP, they're not going to be probably familiar with, the coexistence of FHA and PCOS and being able to differentiate those properly.
There's also a really weird situation that can occur where you can actually get symptom resolution, like some of your PCOS symptom resolution, by becoming functionally amenorrheic, like FHA, right? Because all of a sudden you start getting a reduction in androgens, you start getting a reduction in all of these other things, all these other hormones, because you've basically shut down your endocrine system because you're not feeding yourself, So you can get this kind of temporary like symptom resolution and go, what I'm doing is working. Yes, I've figured it out. But it's actually a long-term negative. You get this short-term like, oh, I'm in a good place because you've got a reduction in circulating hormones because you're basically completely infertile because you've shut yourself down. Well, not completely, but you're infertile because you've shut yourself down from eating so little food. And yeah, you get this mild symptom reduction, but it's not the long-term thing that we want, because what happens when you start eating more food, or what happens when you actually want to have a child, or what happens when, oh, my actual bone mineral density is now fucked, It's like all of these things we have to be thinking longer term, But anyway, look, that's the calorie side of things. Carbohydrates, because this I know is the next thing, right? Because we're talking about insulin sensitivity. Maybe you want to talk about that in a second, Nicola, in terms of like, what is insulin sensitivity? Why should we care about it, right? But we're talking about that, like we often bring it up, it's like, oh, we talk about it in a general context, but then you talk about PCOS and people will say insulin sensitivity, or my carb tolerance, or they'll talk about carbohydrates. So there's a lot of talk about carbohydrates in the PCOS sphere, and a lot of the research on it is kind of mixed. So obviously that, again, leads to a gap in the market. But what's the story here? Let's talk about this carbohydrate stuff. Why do we care about carbohydrates? Let's say we get our calories really dialed in. We're like, yes, okay, I know I should be eating this much. I've done, we often recommend there's 2 different methods you can use to really figure out your calories. You can plug all your data into one of these online calculators. That's fine. Gives you an idea, gives you a snapshot of like, this is where I think maybe I should be at. But what we often recommend is just tracking your food for 7 to 10 days, well, 3 to 10 days really, and then getting an average and looking at your body weight and going, okay, so my body weight stayed the same, eating this many calories, that's probably in and around maintenance calories, right? And let's assume we're looking for weight loss here. Maybe we're eating 200 to 300 below that maintenance calories, right? So let's assume we've done that. But now we want to set our macros. We've got MyFitnessPal or one of the other tracking apps. Where do I set my calories, right? Or sorry, not my calories. I've set my calories. Where do I set my carbs? Where do I set everything else?
Yeah, so carbs is a funny one, because I think before it was, just cut out carbs for women with PCOS. That was the general recommendation. What we know now is kind of more of a moderate carbohydrate intake, kind of even sub kind of 45% is a good place for a lot of women. Again, it's not a good to make a blanket recommendation, because insulin sensitivity will vary between women with PCOS, particularly like the lean phenotype might have kind of better insulin sensitivity than the kind of higher BMI phenotype. So you're looking not only at carb quantity, so that kind of sub 45%, but also the quality. So focusing primarily on complex carbohydrates, or kind of lower GI or low foods that have a lower kind of glycemic load as well. Just so when you're kind of having those carbohydrates, that they're not kind of like hitting that bloodstream as quickly. And then kind of pairing your carbohydrate meals kind of with a source of protein, kind of with a source of fats, and if you're having kind of the bulk of your carbohydrates around training. So with the insulin sensitivity, so insulin essentially, when you have a carbohydrate like based meal or whatever, and that kind of glucose or sugar kind of hits your bloodstream, insulin will help take it kind of from the bloodstream and kind of into your cells, into your muscles to be used for energy. So with insulin kind of more resistant states, is we need more insulin to be able to do that. So you kind of develop more of a kind of hyperinsulinemia. And again, that has knock-on effects on our hormonal kind of endocrine system as well, and why you see a lot of, you know, menstrual irregularities and effects on thyroid, cortisol, etc. It's a really complex interplay of your hormones. But that's why there is such a focus on carbohydrates. But again, it's not about tanking your carbohydrates as we used to think it is. It's more of a moderate carbohydrate, primarily focusing on complex carbs that have kind of, you know, kind of lower GI. But that's kind of the main thing. And then again, you're looking at kind of like a carb tolerance, I'm saying kind of quote unquote. And that's just that carbohydrates will affect people differently. And that's one thing with clients is not only kind of mapping out, okay, are we having, you know, the majority of our energy intake at one half of the day over the other, or that we spread out evenly? Do we have a carb source? But also the amount of carbs that you're having, or how are you feeling afterwards? Are you someone that, you know, after you have, you know, 2 sweet potatoes, are you falling asleep? Do you need caffeine after you have 2 sweet potatoes? Or are you someone that, you know, you have a certain amount of carbs in a meal and you're suddenly ravenous still like 2 hours later? And so kind of looking at that, we need to kind of not only adjust kind of carb intake, but maybe adjust protein intake, or maybe adding an extra fat source onto your meal. So again, it can be quite complex. And the kind of tracking that kind of thing can seem very tedious, but even doing that for like a couple of days, just seeing how you feel after meals and kind of your satiety, you will start notice trends. So even doing that for a couple of days, you can gain kind of a lot of insight into how not only carbohydrates, but the meals that you eat, how they affect you.
Yeah, like the way I always think of this stuff, or again, I'm an idiot, so I have to use analogies. But the way I always think of like insulin sensitivity, like insulin, like again, I did in preparation for this read a lot of stuff on like Reddit and different things, like people just asking about PCOS, being like, oh, what's the story here? And the way people talk about insulin, it can be very misleading, right? We'll talk about insulin in terms of like it has 2 main roles, right? We'll just say 2, right? It has a multitude of roles, but let's just categorize it as 2, right? The first one is kind of like what you explained there. Insulin is helping get glucose into the cell here, right? So the way I often use the metaphor for that is, you can imagine insulin is kind of like the bouncer at the door. You're trying to get into the club, your glucose, you're all dressed up, you look great, you know, you're trying to get into the cell. That's the club, right? That's where you want to be, right? Or at least that's where the body wants you to be. They don't want you on the streets, right? That's the bloodstream, right? So insulin is the bouncer at the door, right? So when you have enough glucose in the cell, insulin goes up and goes, right, I'm going to knock on the door. Yeah, there's enough room, get into the cell, right? But now let's assume we have some sort of situation where we're a little bit resistant to that signal, right? Now we can imagine you're a little bit resistant. The bouncer's not going to let you in because that cell is already full. That club is already, it's pretty busy in there. You're going to wait out here in the bloodstream for a while, right? Now they might knock on the door. Takes a little bit while for, you know, the people in there to let you in, you know, or maybe they actually, you know, they're just not listening to that signal. Knock on the door, insulin's going, I'm knocking on the door. Insulin goes, all right, look, I need one of my mates over here. Brings up his mate, right? Okay, the 2 of us are going to knock on the door. Now we've got more insulin in the bloodstream, right? We've got more glucose in the bloodstream. There's a queue building up outside, right? So that's kind of what's happening when you're insulin resistant. You're just not sensitive to that knock on the door, right? Now that can be caused by a number of things. It can be caused by poor sleep, right? That's one of the things we'll talk about later on. Like if you have poorer sleep, we can imagine that the guy who's doing the in between, like, yeah, the insulin knocks on the door, but the guy who's supposed to open the door, he's a bit tired. He's like, oh, was that a knock? He's half asleep, right? So when we're, you know, tired, we haven't slept enough, we don't want to have that, right? Because it increases our insulin resistance, right? But there are a number of other things. Being overweight or having more fat mass tends to lead to a situation where we're more insulin resistant. Because again, when you think about that, if this is just glucose, it's just energy effectively. That's how the body thinks of it, right? That's, again, very simplified. But if we have a cell that already has a lot of, you know, energy stored in it, right? It has fat stored in it, right? Adipose tissue, right? Or there's adipose tissue around that cell signaling to it going, yeah, look, we have enough energy around here. We're all good, right? That insulin signal is going to be a little bit dampened. It's going to be a little bit, where it's a bit busy in there. You're not going to get in, right? We can also do other things to improve our insulin sensitivity, right? We can do exercise, right? So exercise improves your insulin sensitivity because it basically uses up the people in the club, right? Again, bit grim, but it uses them up, right? They're all done, right? Because you've used up the energy in your cell. You've done all this, contractions. You've gone to the gym. You've gone for a walk. You've done whatever. So the cell is a bit energy deficient now. We've got rid of all those people. We've processed them, whatever, right? So insulin now knocks and goes, yeah, you can go straight in. Half the time it doesn't even need insulin to knock, right? To go in. There's non-insulin mediated ways of getting glucose into the cell, right? So again, that'll be important later on when we talk about exercise and stuff, right? That's one thing. So insulin, you can think of it as a kind of energy storage hormone. Now, that's what oftentimes people will think of it as, right? But insulin also plays a role in regulating our endocrine system or our hormonal system, right? Because again, when we talked about amenorrhea in the last podcast or whenever it was, we're talking about a situation where your body is getting a signal from the food that you eat and going, we're in a low energy environment, right? We have to down regulate some of these things, these hormones, these, your menstrual cycle, all these different things, reproductive cycle, so that I can kind of, conserve energy, right? A lot of that is being signaled through insulin. So insulin is also signaling how many people are in the cells, how many people are in the bloodstream. I often think of this, again, using that same analogy. It's like that bouncer who's knocking on the door. He has one of those little clicky counters, right? And he's clicking the amount of people. He's like, all right, there's this much. And that click is going back to headquarters and going, right, Jesus, actually, we need to open up more clubs, or we need to, start doing stuff with this insulin, or, there's a lot of people in the streets here, or there's not a lot of people in the streets here. It's basically just a management system, right? That's the way I think of it. That's the metaphor, the analogy that I use. Again, I'm an idiot, so take that for what you will. But that helps me really understand the stuff, because then I can go, okay, well, what are we actually trying to do here when we manipulate our calories? We're trying to create an environment where there's less people in the club, right? We're trying to lose some fat here because that's going to make these cells a little bit emptier, right? So there's more room in the club. Happy days, right? When we're trying to manipulate our carbohydrates, we're kind of trying to manipulate how many people are in the bloodstream. Now, that's very simplified because there is also fat in the bloodstream and, a lot of other things, but we're trying to manipulate that so that we don't have a huge buildup of, we've got a lot of carbohydrates, a lot of glucose in the bloodstream straight away. So if you eat some sugar, for example, that's going to get into the bloodstream a lot quicker, right? So now all of a sudden, the bouncer's knocking on the door going, geez, there's loads of people out here. That's to knock on the door a lot more, right? So he's going to go, right, I'm doing a lot of work here. I'm going to call my mates. So you get this higher insulin response, right? But then all of a sudden it's empty. The streets are empty, but you still have all these insulin molecules, swimming around, right? So that's one case. But if we think about what we're trying to do here, we don't want to have, in PCOS, we don't want to have this super high signaling of, we have a lot of energy available, right? Because that's going to lead to a situation where you actually increase your hormone, synthesis, your hormonal output, if you will. You're going to put yourself in a situation where you produce more androgens. Because if you said to me right now, I have someone, I want to increase my testosterone, I'm going to put them on a higher carbohydrate diet and keep them lean, right? Because that's going to get their testosterone as high as it can be, because that's getting insulin to signal, you have a lot of energy available. Cool, let's make all the hormones that we want, right? In PCOS, we don't want that. We want insulin to be at a nice baseline level. It's not super high, so you're getting this cascade of, hyperandrogenism, etc. So what we're trying to do here is control the amount of glucose that gets into the bloodstream, right? And then we're also trying to make sure that the club has enough capacity for them, right? So we can do that from both perspectives, and we'll talk about exercise and sleep and stuff in a minute as well. But when we're talking about the carbohydrates we eat in the diet, what we want to do is we want to control the amount, first of all, so the quantity, and then we also want to control the quality so that they're being dripped out into the bloodstream, right? So we have quantity. So let's say we've got our calories, we can go, right, how much do we want? Again, you used to have this kind of perspective in the medical sphere or whatever, where it's like, we just want to get carbs as low as possible, right? And again, you can imagine that's okay, but it generally isn't the best longer term it's a hard diet to follow as well. Really low carb diets are quite hard to follow, right? Now, you might get some great weight loss with that. For some people, it's really helpful, but again, we potentially run into issues down the road, right? So we're kind of going, right, we want somewhere in the range of, 30 to 50% of the diet from carbohydrates, right? Let's just set that as the baseline, right? Now, oftentimes I'll set protein and fats first, which we'll talk about in a second. And then I'll be like, right, the rest of it is coming from carbohydrates, right? We'll say we start that. We'll just say 50% here, right? But then we're also looking at our food selection choices. We're going, right, we need to actually choose foods that are higher in fiber or have a lower glycemic index, right? And this is oftentimes whole grains or, starchier carbohydrates that have a lot more fiber in them, like potatoes, rather than like, white pasta or something like that. We're choosing foods that result in less glucose immediately hitting the bloodstream. And then we're also choosing a meal pattern that also reduces that, such as adding some fats to the meal, adding some protein to the meal, right? So that's kind of the way I think of it. And I often explain it like that. But I'm interested if either of you have any extra thoughts on that.
No, I really enjoyed that. Thank you.
Yeah, I agree. I mean, like, I think that you can, you break this down into two different categories. One, the diet that is aiming at weight loss, like weight loss and the presence of an energy deficit independently and together create better insulin sensitivity. So they're going to improve your insulin sensitivity. They're going to lower levels of insulin that's being released as well. And those two things often, but not always, go together. So that's one part of this. But there's also, like, as we've discussed throughout this podcast, the goal isn't always just weight loss. So you can improve insulin sensitivity, you can improve glucose regulation in the absence of weight loss as well. And that comes down to increasing your dietary fiber, more complex carbohydrates than simple carbohydrates. Those things can help for sure. Calorie management still matters, like, because it's not like if you're not losing weight, you just get to eat as much as you want. You still want to be around maintenance. And those things are still going to be important for glucose regulation. Obviously, exercise, all the things that we're going to discuss, is incredibly important as well for both insulin dependent and non-insulin dependent glucose uptake. And yeah, protein intake as well. So all those things in the diet are going to be helpful.
Fantastic. Right. So let's assume we've got the carbs sorted, right? We're eating whatever, 30 to 50%, somewhere in around there. We're looking, like Nicola said, we're looking at a response to that. Do we feel good after that? Do we feel hungry? Like, what's the story there, right? After that, again, we're really spreading that out throughout the day. In general, we're not going, oh, I eat all my carbs at dinner or whatever, right? Like, that's fine, but we don't really want to have those huge bolus doses, right? Because again, that's more glucose in the bloodstream regardless. We've eaten a lot of them, right? So spread it out throughout the day, low glycemic index, possibly higher fiber. We're pairing that with protein and fats at each of our meals, ideally, right? After that, what we probably want to do is set our protein, right? I generally set protein first because it's just, I think it's one of the more important ones. I often set fiber then after it, which people don't generally do. But either way, protein, it seems to be that roughly 30% of the diet from protein seems to be effective for PCOS, right? Now, there's been research in both sides of things going like, well, what's a low protein diet? How does that affect things? How does a higher protein diet, how does that affect things? And like, there's mixed results on both sides of that. In general, though, like, you could say that some amino acids are insulinogenic, so they will actually result in insulin being secreted, right? But in general, if you eat a protein meal and a carbohydrate meal, it's leading to a better glucose management, a better area under the curve, if you want to call it like that, of your glucose staying within a nice range, right? So we're generally going, right, how much protein do we need? You could argue the point on this, especially in someone that is overweight. You could be like, well, how much do we actually need to get? Because again, we talked about this before, if we base protein on lean body mass versus if we base protein needs on body mass, you're going to get two completely different numbers if you use the same like grams per kilo amount, right? So like in general, I'm probably setting protein somewhere in the range of 1.5 to 2.5 grams per kilo. If we've got this like lean PCOS, I might go up to that kind of 2 grams. That's generally, I'll be like, all right, you're leaner, let's go for the 2, maybe 2.2 grams per kilo. But in general, if you're like, right, there's a bit of overweight here, like we're fatter than we want to be, I'm probably just going to go 1.5 in and around there. Like, yeah, we can modify it based on the person's preference. Like, for example, they might also be a vegan or a vegetarian, and it might be harder to get that much protein. So we have to modify that. But in my experience, I'm like, look, 1.5 to 2.5, somewhere in that range. Once you're getting in there, I'm quite happy. I don't think we need to belabor the point and go, oh, well, actually, 1.75 is actually the ideal, perfect amount. But do either of you guys have any difference of opinion there?
No, definitely not. It's just about getting it in regularly. Protein has the dual role of kind of helping with weight loss, kind of increasing satiety, and then just helping with the glycemic response as well. So it is just about kind of drilling that point home as well. It's like, a lot of women can kind of skim out on protein, particularly if they're leaning more towards plant-based diets. So it is just kind of drilling home the importance of why we're doing that, more than anything.
And also it can improve muscle mass, which is ideal here, because then when we're exercising, we have this kind of sink. Well, even when we're not exercising, we have this kind of sink for glucose in terms of actually having muscle mass, right? So exercising, resistance training especially, which we'll talk about in a second, and eating enough protein, that's going to be really beneficial for getting your blood glucose in a really good level, right? Now, fats, we both want to think about quality and quantity again with this stuff. But what are your thoughts here on fats, Nicola?
Yeah, so like you're saying, yeah, quality and quantity. So you want to prioritize mostly polyunsaturated fats, particularly our omega-3 fatty acids. They can help with insulin sensitivity, inflammation. And the opposite then is true of diets that are high in saturated fats and trans fats. So PCOS can be associated with dyslipidemia. So it's important to, kind of have that counterbalance of like our, quote unquote, good fats and the omegas, and just making sure that the majority of the diet isn't composed of saturated fats.
Again, going back to the same analogy I used earlier on, sorry, I always do this because I'm an idiot. But like saturated fats, they're very like if you want to think of like sterically, they're very easy to pack really closely together. So these fats make up your cell membrane, right? And if you have a lot of saturated fats in the diet, they're potentially making up more of that cell membrane, right? So as a result of that, those cells are a little bit more packed tightly together. And this would be, using the analogy I used earlier on, that would be like that door to the club. It's a really thick, heavy fire door. So when insulin knocks on the door, the sound inside, you don't really hear that, right? Whereas really more polyunsaturated fats or even monounsaturated fats, that door is a little bit easier to hear the signal, right? That's just, the analogy I often use, right? That's not perfect, but whatever, right? And then fats, in terms of the quantity that we're consuming, we're probably just going to use whatever calories we have left. We're going to go, right, we've set protein, we've set our carbohydrates, we're trying to get like a higher fiber, lower glycemic index carbohydrates source. And then whatever calories we have left, we're going to go for fats, and we're going to try to prioritize polyunsaturated fats and monounsaturated fats versus saturated fats, right? And again, we're spreading the calories throughout the day. We're not doing any like skipping meals, etc. And then what we're ultimately looking for is probably in this kind of range of 5 to 10% weight loss if we're trying to lose weight as an insulin sensitizing, thing. And that seems to improve fertility and a lot of the other symptoms associated with PCOS, right? So that's the diet side of things. And that's, again, people are like, wow, how do I set this stuff? There you go. There's the blueprint, right? Now, obviously, you would still have to modify things over time. And that's like what we do in coaching. We're going to go, right, this is the best case scenario or best starting point that we can think of, but it's going to need to be modified over time, right? Now, training side of things, this is obviously something that we also need to deal with, because this has effects in terms of building muscle. It has effects in terms of bone mineral density. It has effects in terms of, just glucose disposal in general, and insulin sensitizing in general. So training, Gary, and I ask you, because you've been quiet for a while, what's the story with training?
Lift weights and do your aerobic exercise. That's simple. In all seriousness, the recommendations are very similar to what we would give to anyone else. Okay, so you want to train, absolutely, first and foremost. We know, again, that exercising, both the process and the adaptations can increase both insulin and non-insulin dependent glucose uptake if we're focused solely on the insulin sensitizing side of things. It's really, really important. And one of the good things I think that is nice for women with PCOS is that sometimes you actually have a more favorable response to training due to the hyperandrogenic state. So as we said at the beginning of the podcast, people with PCOS tend to be overrepresented to some degree in high-level sport because there is some degree of advantage conferred by that hyperandrogenic state. So you will probably have a favorable response to training. I have, in saying that, I have met a couple of women over the years who've, one in person and then a couple who messaged me, who have PCOS, and they were actually concerned about growing muscle too fast. And like generally when people say this to me, I'm like, I'll give it a rest. Like, you're not gaining muscle too fast.
I wish I could gain muscle too fast. Like,
yeah, like, you know, you're like, oh, it's the classic meme, like, oh, girls think they're going to get bulky. You're not going to get bulky. But like, these girls were jacked, you know, they were jacked. And, you know, one of them was like, look at my shoulders. Like, I do not want my shoulders to be any bigger than this. And I'm like, okay, this is one of those rare scenarios where I'm like, fair enough. Okay. If you're someone with a hyperandrogenic state and you're gaining more muscle than you would like, then maybe bias your training a little bit more towards the aerobic side of things. But I think, to be fair, still, even with PCOS, most people are not going to be in that position. Most people are going to be happy to gain a bit of muscle, to get a bit stronger. And in general, what I would recommend is somewhere between at least 3 days of resistance training per week, and then generally trying to meet the aerobic training guidelines for health. Not any different for PCOS. I'd still aim for 150 to 300 minutes of moderate intensity aerobic exercise per week, and then add on your resistance training as you wish. So yeah, I think it's really important from a health perspective here, because like the insulin sensitivity side of things to the side, we know that we're dealing with potentially an elevated cardiometabolic risk here. So even if you're not, you know, going to improve your body weight or cosmetics aside, the process of exercising is going to reduce that cardiometabolic risk. And that's something that's obviously very important long-term.
100%. Nicola, what are your thoughts?
Yeah, just a couple of things to add to that one, like I was saying about fasted training as well. Just kind of being careful with that can increase your cortisol. Another thing is like checking kind of where someone's starting off. Again, like if someone's, you know, 100 plus kg, that, you know, kind of, you know, running or that kind of getting to the gym 3 days a week might not be realistic. They might not want to go to the gym. They might not, you know, feel comfortable yet going to the gym. So even just getting someone out walking 3 days a week is a great start. So it is just monitoring where, like, the ideal scenario is getting someone doing their aerobic fitness, is getting them into the gym, doing their training. But like I have there, just kind of sometimes just like sitting less, you know, if they've a sedentary job, you know, just getting up, moving around every hour can be a really good start. And then over time, once they kind of get more confident, trying to get someone to do more resistance training. And then another thing that I was just mentioning was just HIIT training as well. Again, if you're a mixture between, you know, in a calorie deficit, already in a highly stressed state, doing like a high intensity training, again, can just be counterproductive of just, you know, increasing your cortisol. So I would, particularly if you're dieting, if you're someone with PCOS, I would be leaning more towards kind of a lower intensity aerobic combined with resistance training.
100%. Like the way I kind of think about this is like you want to do a mix of resistance training and aerobic training. And with aerobic training, you want to keep it in that kind of actual aerobic zone. Like you don't want to be pushing into those kind of anaerobic zones. You could argue that maybe it's beneficial because, you know, they're the zones that increase glycolysis and you're really using the carbohydrates. But the trade-off in fatigue, the trade-off in terms of stress and all that kind of stuff, it's just not worth it, right? So what I generally do is I'll be like, right, we're going to have 2 to 3, maybe 2 to 4 training sessions a week, resistance training wise. In those sessions, I'm probably going to do some aerobic conditioning at the end. You know, let's say you're at an hour of training, we're doing 40 minutes of weights, 20 minutes of aerobic conditioning, right? And then on all your other days, we're at least doing some sort of activity. We're trying to keep ourselves active. Now that could be walking, that could be whatever else. Now that's fantastic. Ideal case scenario here, we're doing weights 3 days a week. We're doing cardio training 3 days a week on top of that as well. Let's say we're doing 6 days a week straight through. We're doing alternating days, cardio resistance, 1 day off, right? And that, if you're like, right, I want to really just dial everything in, that's going to build you muscle. That's going to always keep you in this kind of post-exercise state of, increased insulin sensitivity. It's going to really improve your cardiovascular fitness like very quickly. So it hits everything. Obviously that means that you're in the gym 6 days a week, which is not, for a lot of people, that's a little bit excessive, but let's assume, right, you want to get this dialed in 3 days a week with a mix of cardio and resistance training, happy days. On top of that, then we just start layering in that kind of general day-to-day activity. We're trying to get some more walks in throughout the day. We're basically just trying to keep ourselves, using glucose, using energy, again, putting ourselves potentially in a calorie deficit here by doing more activity throughout the day, especially if we have weight to lose. If we're in that lean PCOS, maybe you don't want to necessarily put yourself into a calorie deficit, but we want to basically be active throughout the day. You can use like a watch or whatever, like those fitness tracking watches, and track your steps and set yourself, I'm going to hit 10,000 steps per day. I'm going to make sure I spread that out. That can be really good, but it's just a proxy. It's not perfect, but it can be really good in terms of keeping you active throughout the day, But do either of you have anything else to say on training? No?
No, not really.
Fantastic. Let's get on to lifestyle, because this is a very quick one, right? In terms of lifestyle, we've got 3 things we often talk about in terms of overall lifestyle management. We've got non-exercise activity thermogenesis, which we kind of just touched on there a second ago, in terms of get out for some walks, be generally active. You could argue that doing something like 10-minute walks after meals can be really good for using up, like creating a bit of a sink for the glucose for the food that you've just eaten, right? So being frequently active, that's what we want to do. The next thing then is we want to make sure that sleep is really dialed in, right? We're looking for 7 to 9 hours per night. And again, we talked about that when I was doing my analogy, my metaphor. So we want to make sure that sleep is in a good place. We've talked about sleep before on the podcast. Don't think we need to labor the point here, but sleep 7 to 9 hours, get it in. It will improve things, right? Stress management. This is actually really important for everyone, but especially for PCOS. So we do need to do some sort of stress management techniques, whether that's, you're just, setting up your life in a way that's less stressful. Like you don't have to be like, I get up at 5 a.m. and I do this, and, like having a really stressful, always on the go lifestyle. Like Gary, you've been doing exams the last while. Nicola, you work as a doctor. So both of your lives are stressful at the moment, but if you were dealing with PCOS here and you're kind of, I really need to dial this in, you're going to look at that lifestyle schedule that you have and go, okay, where can I reduce stress? How can I reduce that stress in my life? Now, sometimes, people can't do it. Gary, you're doing exams. It's not like you can go, sorry, I'm just going to ring up my professor there and say, can I just not do these exams? It's not going to happen, right?
I'm worried about my ovaries, doc.
But anyway, so stress management, we've talked about it previously on the podcast. We will definitely be talking about it in future on the podcast, but we want to do some sort of stress management, right? I don't know if either of you guys have anything to say on either sleep, frequent activity, or stress management.
Yeah, I think with stress management is probably one of the most helpful things that you can do. But unfortunately, like a lot of the advice for stress management is just really cringy. It's just kind of like meditate, do some yoga. So it is just taking a look at your life and saying, hey, what are the biggest things that are stressing me out, and which of these can I actually change? Because, sitting down being like, okay, I guess I'll schedule in some journaling. It's really not helpful for actually the majority of people, but just taking a look and be like, what can I actually change here? And just focusing on that can be a really good start.
Yeah, and look, there's 1,000,001 stress management techniques out there. You can look them all up. Some of them are, like you said, incredibly cringy. Some of them are a little bit more practical, and they're like, right, actually that makes sense. I can just do that, So there's 2 sections left on this. Now, we don't want to go too long extra on the podcast, but with these 2, we can kind of get through them quite quickly. Because look, one of the things is supplements, and the other thing is prescription drugs. Now, if you're talking to your doctor, they're the one that's going to prescribe drugs, right? And what I'll say is all of the issues that people try to solve with supplements, they're better managed with prescription drugs, So if you really have that issue, talk to your doctor and they'll be able to help you with specific prescription drugs, you know. And maybe we'll just start on the prescription drugs, just quickly go through them, because I know, again, going on those forums, I saw people going like, I don't even know what this drug does, and like they're just being told their doctor says to take this. But there's a number of drugs that are recommended for PCOS. We've got metformin, we've got, you know, I can't remember, oral contraceptive pills. We've also got finasteride, you know, it's often recommended. We've got weight loss drugs or weight loss supporting drugs. We've got statins, and then we've got some, we'll call them fertility drugs, right? I don't know which one of you likes drugs more. So I don't know, either of you can take it away here.
Yeah, so firstly, I suppose it's important to understand that some of these drugs are, I guess, dealing with some of the side effects of PCOS or the symptoms of PCOS, and therefore they're not general recommendations. Like, for example, something like finasteride or minoxidil for androgenic alopecia, like that's assuming that someone is dealing with you wrote down on the thing, reduce excess hair growth. So it's kind of both. Like finasteride and minoxidil can be used for the hair growth irregularities in PCOS. There's kind of two sides to that. You can get loss of hair or thinning of your hair, potentially little bald patches in your hair, and then also the excess hair growth. So depending on what you're dealing with, drugs can be prescribed accordingly. Statins, obviously, if you've elevated cardiovascular risk, or you've got high levels of LDL, sometimes you don't necessarily need specific lipid profile to be prescribed a statin. It depends on your baseline cardiovascular risk, but that's something that might be prescribed. Again, that's not a blanket recommendation as such. Metformin is something that tends to be quite efficacious. It improves insulin sensitivity, so that's something that is obviously important as part of this process. And that can also help with weight loss if you're engaging in the weight loss process. It's likely that a lot more weight loss drugs will probably make their way into PCOS treatment in the coming years. You know, you've seen recent studies on liraglutide, semaglutide, kind of preliminary trials that have been quite promising for weight loss and obesity. And given the pathophysiology of PCOS, I would see those as being probably quite useful in PCOS, but just haven't been studied properly yet. So that's likely to occur at some stage. And then you've got the drugs that I guess are a bit more central to the pathophysiology of PCOS, the female drugs. So the oral contraceptive pill is something that actually is quite efficacious in PCOS. If you're presenting with acne, those symptoms of hirsutism, insulin resistance, etc., those central features that we mentioned, the oral contraceptive pill is something that is recommended as first-line treatment in guidelines. So that is something that's worth considering. And the reason that that's really important to discuss and really important to look into is because you actually see a lot of people who kind of throw out this statement without actually looking at the evidence, saying that, oh, doctors just love prescribing the pill to mask PCOS. And it's like, not really, you know, that's not the goal. It's not just to mask it and that they could just get to the root cause. It's that this actually helps people with PCOS. It's not just masking it. You can still do all the other things that we've mentioned alongside taking the oral contraceptive pill. So that's why you should just speak to your doctor with in relation to any drugs that you're going to take, obviously, and recognize that any drugs that would be prescribed would be dependent on your specific phenotype. We've mentioned already that there's huge heterogeneity in how someone might present with PCOS, and therefore you shouldn't expect a generic recommendation for diet or training or prescription drugs or supplements.
100%. Nicola, do you have anything else to add to that, seeing as you're actually a doctor and Gary's just a pretender?
There are just two things that Gary mentioned it already about the OCP. Like, you know, a lot of people have their pitchforks out for like oral contraceptives, and the thing is that they are really helpful for a lot of women, and particularly, you know, preventing pregnancy. So I think, you know, again, particularly like on social media, people are like, come off the oral contraceptive pill, like it does like all these negative side effects, and there are those negative parts of it to consider. But as well, kind of coming off that, you know, trying to track your natural cycles just isn't something that's realistic for a lot of people. So if you are someone that is like hearing all of this, you know, that you need to come off the pill, again, you know, there's there's nothing wrong with you staying on the pill if that's what kind of suits you and your lifestyle. So it's just to be, you know, mindful of that as well, that there are benefits to being on it. And then the second thing then, about fertility. So I mentioned earlier, you know, that it's a huge cause of infertility, but there are things that can be done for that. And there are medications like clomiphene that we were mentioning that can help with ovulation. So if you're kind of listening to it and you're like, what am I going to do? Or I might have PCOS, am I infertile? There's so much that can be done for it. So it's not something to overly worry about. Speak to your doctor.
Yeah, exactly. And I mentioned earlier on that like you see a lot of correlation between PCOS and people who use like IVF and, you know, different fertility methods. And this is one of those things where it's like, is this chicken or the egg? It's like you have populations, PCOS seems to run in families. These populations are using increased like enhanced fertility methods, and all of a sudden their daughter has PCOS, and they're like, oh, it must be the enhanced fertility methods. And it's like, well, why did they need those enhanced fertility methods before? Oh, because their mother also had PCOS and she was conceived without any of these like drugs or anything. So it's one of those things where we'll have further clarity on that stuff in the future. You know, we can make all these mechanistic hypotheses or hypothesize about like what's going on, but realistically, we don't fucking know. Again, when we talk about the causes, we don't fucking know, you know? But now supplements, we'll get on to the big one. We're actually just gonna fly through this because realistically, the majority of the supplements are just not that helpful. Right? There's just not a lot of research. Like you can go, like the only reason we're going to go through these is because you will see them brought up. Again, as I said, I went through all these like message boards or whatever. You will see them brought up a lot. You know, people don't want to talk about their diet. They don't want to talk about their training. They're like, well, what supplements can I take? Or what can I do here? And supplements can be potentially really helpful, especially in the cases of deficiency or shoring up a nutrient that you're just struggling to get in the diet. But in general, for PCOS, like supplements are just not doing a whole pile, except for one seems to be quite efficacious, but the rest of them, like they can help, but they're just not, they're not fantastic, you know? So supplements, I'm just gonna go through all of these, the potential reason you might use them, and I'm gonna leave the big hitter for last. So you'll often see berberine recommended for PCOS in these like, you know, supplement things. And that's because berberine works somewhat like metformin. So it's increasing insulin sensitivity here. It's helping with glucose management here. So you could argue, oh, we'll use berberine. That'll help with the insulin stuff that I need to deal with PCOS. But it's good. Like, don't get me wrong. Like, I think berberine is actually a fantastic supplement, but it also pales in comparison to just managing your diet and managing your training. Right, so it's just not that effective, right? N-acetylcysteine, NAC, you'll often see, oh, this is really good. That can improve insulin sensitivity. It can also improve fertility in certain cases, and improve health, immunity. There's a few different things that it can do, but ultimately, look, it's not doing anything to really like cure the issues with PCOS. It can be nice to add to the diet. Like I take N-acetylcysteine myself. I think, you know, for a few things that I think are beneficial for it, but I wouldn't be just generically going, oh, everyone needs to take this, or everyone with PCOS needs to take this. L-carnitine, it increases fat metabolism. Well, it doesn't actually increase it, it just supports fat metabolism. So people often go, oh yeah, I'm going to use that. L-carnitine also does increase, well, in some studies, increase androgen receptor density. So this is often recommended, but it wouldn't be something that I'd be like, yeah, look, you have a hyperandrogenism, let's increase your androgen receptors. Like for me, it just doesn't necessarily make a huge amount of sense. And maybe some people find a benefit from it, but it's a no from me, you know. Magnesium is actually one of the ones that I think a lot of people should in general supplement with, but you can also just get it from your diet if you eat more leafy greens, which would be supportive of, you know, better craving management, better diet in general. But magnesium does have a lot of roles, a lot of, you know, potential benefits to people with PCOS. With all of these different ones, you can just go on examine.com and type them in, and you'll get the research on them in a really like nice, easy to read, understand format. You know, there's other supplements such as this supplement called Vitex. There's, you know, a huge big name to it. I'm not going to try to pronounce it or anything, and that's often touted as being able to improve hormone balance in women, and it can help in certain cases. But with PCOS, like I just don't see the research to support it. It's just not something that I'd be like, yeah, like this is really well supported. Everyone should be taking this. Zinc can help with hormone balance. It also can help with increasing androgens. So maybe not, but it is something that is required in the diet, but you can get it from the diet. So you don't necessarily need to supplement. Chromium as well can be quite beneficial, improving insulin sensitivity. But again, you can get this from the diet. You also don't need a huge amount of it. And it's also just not that effective. Like it pales in comparison to going for a walk, for example, so get your priorities straight. Omega-3s, I actually think omega-3s are fantastic, but this goes back to basically it just being a dietary supplement. It's basically just going, all right, I'm just not getting enough polyunsaturated fats in my diet. I want to take some omega-3s to help with that, right? So you could argue, yeah, take some omega-3s, but you could just eat some fish, So again, not something that's a necessity. Vitamin D, look, I think vitamin D is fantastic. It does help with hormone balance. It helps with insulin sensitivity. It helps with a huge number of things. But as long as you're within the vitamin D range, like your D level is in a good place, you don't necessarily need to supplement. If you get enough sun, you don't need to supplement. A lot of people in the Western and Northern world are deficient in vitamin D, or at least subclinically deficient. So increasing your vitamin D could potentially be beneficial. You've also got alpha lipoic acid. This is often touted as increasing insulin sensitivity, but again, pales in comparison to exercise and just managing your diet. So it wouldn't be something that I'd be like, yeah, you need to be taking this. It does have some antioxidant properties, which potentially are beneficial, but it's not fantastic. Caffeine can be used. It does actually increase your insulin sensitivity. It does also potentially make you more energetic, so you can actually get out, do your walks, and do all the stuff that's needed to increase that insulin sensitivity. It does also increase sex hormone binding globulin in a lot of people, especially in women, it seems. But I wouldn't be necessarily using it for that purpose. Now, the reason you might want to increase your sex hormone binding globulin is because it's going to bind up that androgen that we don't want, those androgens that we don't necessarily want in PCOS. And that's a good thought process, but it is also like sex hormone binding globulin is often thought of like, oh, it's going to bind these up so they're not going to be available for use. And that's not really the case. Like even when it's bound, like the testosterone or whatever can still have effects on the cell, so I wouldn't be digging too deep into that. Glutamine is often touted as being good for cravings, and yeah, like it can for some people, but it's basically just because you're eating something that kind of tastes like sugar, well, it doesn't actually taste like sugar, but your body recognizes that you have receptors and stuff in your intestinal lining that's like, oh, I've gotten some amino acid here. Your intestines do enjoy using glutamine for a lot of different processes, so it kind of just gives you this false sense of being full, I'd rather just see you manage the diet in general so that you don't get these cravings, Melatonin is often recommended as well for people with PCOS because there can be sleep disturbances, and obviously improving sleep, can be really beneficial. Melatonin is actually illegal in a lot of countries, including Ireland, I think. I don't think it's illegal in England where I am, but that is something that you have to talk to your doctor about potentially. And also, I'd rather just see you do really good sleep practices before you start thinking, I need to get some melatonin into me. I need to order this on some black market website. It's just not going to be a game changer unless you're in a position where you've tried everything else and you just cannot get sleep dialed in, so that's the majority of supplements. The one that does seem to be most effective for PCOS is inositol. It does have a lot of things that would potentially be beneficial for PCOS in terms of improving menstrual regulation, improving egg quality. It does reduce many of the symptoms of PCOS. We ideally want to get, inositol is basically just a sugar, right? So you're basically just taking a sugar, which, seems a bit counterintuitive when we've been talking about, well, we want to reduce the glucose in our bloodstream, etc. But this inositol does seem to act as a signaling molecule in the body. But we ideally want to get it in a form of myo-inositol to D-thyroinositol in a 40-to-1 mix, right? Or 40-to-1 ratio. 40-to-1, I should say. That sounds like 4-to-1. 40-to-1 ratio, that seems to be the most efficacious for helping with PCOS. And then we're taking that in the kind of 2,000 to 4,000 milligram range once per day. Now you can take it spread out throughout the day. Some people recommend that. I often find that if you have to spread out your pills and whatever, you're just less likely to take them. It's just easier just to take them all at once, all at one time, but inositol does seem to be really effective in terms of PCOS management. It isn't necessarily something that you need to discuss with your doctor, but if you are being managed by a doctor, talk to them, be like, should I take inositol? You can go to examine.com, type in inositol PCOS or whatever, and like stuff will come up about that. You can read up on that. You can see if it is something that you potentially want to supplement with. But that's the only one on this list that I'd be like, yeah, like this has relatively good research to support its use in PCOS. But I don't know if either of you guys have any other thoughts on any of those supplements.
Yeah, so I think with the supplements, like you'd really just be looking at introducing them to support the dietary and kind of lifestyle practices that you're already doing. It wouldn't be something that I'd be immediately introducing with anyone, because then you just won't know if it's working or not. But there are some good supplements on the market that you can get, the inositol or the Insulin, however you pronounce it, and it has a couple of the other stuff in it as well. It can have like the berberine or zinc or chromium added as well, which can be helpful. But like you're saying, all those things have shown, efficacy in PCOS, but that doesn't mean you want to be taking 20 tablets. It's just not realistic or helpful.
Yeah, it's just also your issue there half the day fucking chugging tablets.
Yeah, exactly.
Anyway, look, that is PCOS in a nutshell. I don't know if either of you have any kind of closing remarks, because look, and we said with the majority of these podcasts we've done in the female series, like we could literally have split this up and gone into really granular detail on any number of like singular things. This PCOS episode could have been 30 episodes in and of itself. We'll probably do stuff like write some articles or whatever and put them on our website in future, so you can have a reference to kind of look back on, and anything that we find interesting, we can add there or whatever. But right now, guys, do you have any like closing remarks, anything you want to say that we didn't cover or anything at all?
Nope.
No, I think just with PCOS again, don't self-diagnose it. Do go to your doctor, kind of rule out other conditions that might be causing your symptoms. And then if you are someone that is diagnosed with PCOS, it can kind of seem like a long road, and it can seem like that there's not much help. But again, kind of going through some of the things that we went through there, like dietary kind of lifestyle practices, are really helpful. And as well, if you need any help with that, you can contact anyone on the team. We're more than happy to help.
100%. And if you're contacting anyone on the team, we're just going to send it to Nicola. She's just being, what's the word? She's like, just, anyone can help. And it's you that helps.
Volunteered herself.
But anyway, look, we're going to wrap up the podcast. Gary, where can people find us? Give us the old spiel.
Yeah, so on that note of help, Nicola and the rest of us are taking on clients at the moment. So if you are interested in coaching, whether you have PCOS or not, we'd be more than happy to help you. And that includes nutrition only coaching or full coaching with training and nutrition, depending on your needs. So if you are interested in that, you can find further information about that in the description box below. Send an application, or else you can message any of us individually or on the Triage page. If you're not following along with our social media, I would recommend that you do so. Follow Triage Method on Instagram, and then you'll find kind of the central hub of all of our content. Okay, we're doing a lot of collaborative posts these days, so you'll see everyone else's individual posts there as well, and you will learn a lot. We just did a post on PCOS this morning, and we'll do a number of other posts on women's health over the next few weeks to go along with finishing off this podcast series. So that's going to help to complete your education. So make sure you're following. You can also subscribe to our newsletter, the Triage Method newsletter, which goes out each week via email. You can subscribe below, and again, get more free information into your inbox. And I think that's everything. What else do we have? What else do we do? I think that's everything.
Well, that's pretty much it. Anyway, look, I have nothing else to say. Nicola, do you have anything else to say?
No, all good.
Fantastic. Right, we're going to wrap this up. I hope everyone enjoyed this, and I hope you got something from it. And again, if you can share this on your social medias, that really does help us get the word out. Other than that, peace out, guys.